Welcome to another lecture by MedicoMedics, Hepatitis Type B. In this lecture, we will begin with a general introduction of hepatitis B. We will talk about normal physiology and pathophysiology. We will compare the two. Furthermore, we will talk about symptoms, diagnoses, differential diagnoses, and treatment. We will present a small case example and, as always, end with a summary. And for our medical students, we recommend our high-yield review. Now, hepatitis B is a liver infection caused by the hepatitis B virus, often written out as HBV, which can lead to acute or chronic disease, potentially progressing to cirrhosis, liver failure, or hepatocellular carcinoma. Some key features include that it is transmitted via blood, sexual contact, or vertical transmission, like mother to child. Chronic infection is more common when acquired in infancy or in childhood. It is globally prevalent, with high rates in Asia, Africa, and the Western Pacific. Chronic hepatitis type B affects over an estimated 250 million people worldwide. Now let's begin by looking at the normal function of our liver. Some key roles include, first of all, detoxifying blood. So the liver removes toxins, drugs, and harmful substances from our bloodstream. It processes, for example, ammonia, which is a byproduct of protein metabolism, into urea. So the liver helps in processing ammonia into urea. And this is then excreted in our urine. Another part of this role is that it metabolizes, for example, alcohol and clears medications and other environmental chemicals. So that's a major part of our liver in its normal functioning, to detoxify our blood. Another key role is synthesizing proteins. For example, albumin or clotting factors. So the liver produces albumin, which helps maintain the oncotic pressure of blood, essentially to prevent fluid leakage from our blood vessels. And albumin also helps transporting hormones or drugs and fatty acids around. So albumin is a very important protein that we have, produced by our liver. Another one is clotting factors. So the liver synthesizes proteins essential for our blood clotting, like fibrinogen and prothrombin. And these are crucial to preventing excessive bleeding. If you haven't studied our hematology course, or if you haven't studied blood physiology yet, you will. And when you do, you will realize, of course, the crucial role of our clotting factors. When you study, for example, the role of edema, or the symptomatology of edema, relevant in many pathophysiologies and pathologies, you will then come to learn the importance of, for example, albumin. And of course, with the use of medications and metabolism in general, of course, the role of detoxifying our blood is essential. So we have described three absolutely essential roles, all belonging to the organ we're talking about, meaning the liver. So by then learning about liver failure or any issue relating to liver function, you can then go backwards and realize all the potential consequences of a damaged liver. Now, we also have then the third and final one mentioned here, which is the liver's key role in producing bile. So the liver produces bile, which is stored in the gallbladder. And the gallbladder can be seen here resting underneath our liver. So in this gallbladder, you have bile. And this bile that is stored in our gallbladder is released into the small intestine. You have these, without going into more detailed anatomy here, you should probably already know that, but there are these so-called bile ducts connecting with our liver, forming the common bile ducts, continuing down through the pancreas and connecting with our intestine. So the role of bile is also then crucial. Now, bile is essential for digestion and for absorbing fats and fat-soluble vitamins like vitamin A, D, vitamin E, and K. We have a dedicated course lecture on the different vitamins, both the fat-soluble ones and the water-soluble ones. Don't forget to check that out. Furthermore, bile also helps eliminate waste products like bilirubin, which comes from red blood cell breakdown, and excess cholesterol. So, in summary then, from discussing these key roles, the liver detoxifies harmful substances, it produces vital proteins for circulation and clotting, and aids in digestion through bile production, making it therefore a very central organ in maintaining homeostasis. But we also see other crucial roles of the liver. These are storing and metabolizing nutrients like glucose and, as we mentioned, vitamins. So, what happens once we've now understood in general the normal function of the liver? What happens in response to an HBV infection? Well, the inflammation from viral replication disrupts bile flow. And if we have a disrupted bile flow, we will have the presence of jaundice. And this will cause liver cell damage. And in the next slide, we will look more in detail into the pathophysiology. Now, diving a bit deeper into the pathophysiology of hepatitis B. So it starts with the HBV entry. So the virus infects hepatocytes, meaning liver cells, via the NTCP receptor, where it replicates through the process of reverse transcription. Once the virus has entered and it is now replicating, it will follow that there should be an immune response. So the immune system then attacks these infected liver cells, leading to hepatocyte apoptosis, meaning programmed cell death, more specifically liver cell death. And we will then see inflammation. A strong immune response clears the virus if it's acute, while a weak response leads to chronic infection. Now, if there is persistent infection and immune-mediated inflammation, we can have fibrosis developing, leading to even cirrhosis and potential carcinogenesis. So, to simplify it, HBV enters the liver cells, they trigger an immune response or immune fight, and can lead or cause long-term liver damage if it's not cleared. So again, virus enters, starts replicating, our immune system responds to it, and if it's a strong immune response, it should clear the virus. If it's a weak response, we could have the development of a chronic infection. If we have a chronic HBV going on, the persistent infection and therefore the immune-mediated inflammation that follows eventually leads to scarring, so fibrosis, and cell damage, so cirrhosis, potentially even to the development of cancer or carcinogenesis. Now, this may have been a bit too quick, and it's absolutely worth diving more into in more greater detail. So that's what we're going to do right now. Let's look now at the progression from chronic liver inflammation to the development of cirrhosis and liver failure step by step. So you have the stages of liver cirrhosis, beginning with a nice-looking, well-functioning liver, and gradually you see it's deteriorating. So first, we have the chronic liver inflammation, right? It's not acute, it hasn't been cleared. It's now chronic. The cause of it could be persistent liver damage from infections, for example, from hepatitis B or C, from alcohol or other toxins. What is the process underneath this or underlying this? Well, there is ongoing inflammation that causes immune cells to release cytokines. These lead to hepatocyte damage and cell program death, meaning apoptosis. What then continues to happen is that we will have the development of fibrosis. So damaged liver tissue is replaced by scar tissue or collagen depositions. And this is part of the wound healing response. So this is where inflammation becomes a coin with two sides, right? It is actually a good process, inflammation. It's supposed to happen to us. It's healing. Something has invaded your body, it should not be there, so your body responds to it, and your immune system works to clear it out or heal whatever has been damaged. However, as you will come to know, or during the duration of your studies, at some point you will realize that at times what is good, if it's too good or in the wrong place or in the wrong time, can actually have the contradicting effect of becoming bad. So when you have inflammation, you have a lot of fluid going to that space with a lot of immune cells, etc. That's wonderful. But imagine if that's happening in a space that is very small, for example, or when you have a scar or a wound to your skin, let's say. That skin needs to repair itself. But if you've ever studied a burn victim, for example, what happens after that healing has been finished or has occurred? We see that that skin has been has become very tightened. And that leads to the person not being able, for example, to pull his, let's say, fingers apart as he could before, because the damage and the scar tissue has developed in a place where function now has been lost. And that's a perfect example of where healing is good, but in the wrong spot can cause loss of function, for example. So it's similar reasoning here. There is ongoing inflammation, chronic inflammation. This healing process has led to a lot of collagen deposited. And this has therefore developed scar tissue. Once you have this replacement of a lot of scar tissue, you now have impaired function. So fibrosis, almost identical to the example of the burn victim and his skin being unable to separate, let's say, his fingers, fibrosis disrupts the liver's architecture, reducing its ability to perform normal functions like detoxification and protein synthesis. So if you now think back to the normal functioning of the liver and you remember its key role in detoxifying, in producing bile, and producing or synthesizing proteins, all which are super crucial for various parts of our body in general. Now we're going a bit backwards and we're thinking about the cell itself, which gives rise to all of these wonderful functions. Now we're saying that this cell that normally needs to be a certain way has been so damaged by scar tissue now, due to paradoxically being healed from other damage, its architecture has now changed and it looks like this instead. And for whatever reason, when it looks like this, it cannot produce this protein anymore. It's not able to detoxify that toxin, whatever that may be. So now, what will happen over time? We've talked about impaired function. If this progresses, we will then go to cirrhosis. So we leave fibrosis and go on to cirrhosis. Now, advanced fibrosis, over time, what is that? Over time, widespread scarring forms nodules, meaning cirrhosis. And these nodules are irreversible, or they will irreversibly alter liver structure. So we will have a change in the architecture of that area, and it's irreversible, so we can't go back again. So whatever functions that are now lost will be lost. Another important issue that develops is portal hypertension. So scarring restricts blood flow through the liver, leading to an increased pressure in the portal vein. And as you know, blood leaves our left ventricle, traveling through our arteries, delivering blood where it's supposed to, and then travels back through the liver, up the portal vein, up via the inferior vena cava, and back to the right heart, or the right side of our heart. So this portal here, the portal vein, is absolutely crucial in our circulation. So imagine then, if you have this advanced fibrosis, you can have scarring actually blocking or leading to a block of this pathway. So pressure from blood that is trying to go back to our heart for oxygenation will face this increased elevated pressure and can therefore lead to backflow. Now then, moving on to stage number 4 here. So we had normal liver function. We then had the beginning of fibrosis. We also mentioned cirrhosis, characterized by these irreversible nodules. Now we're moving to decompensated cirrhosis, which means that there has been a loss of reserve. The liver can no longer compensate for lost functional tissue. So this kind of tells us something, which is that up until we reach this point or stage, decompensated cirrhosis, the liver seemingly is compensating for lost functional tissue. But now we have reached a stage where there is a loss of this reserve. So what will then be the expected clinical picture? Well, symptoms here include ascites. What is that? It is fluid accumulation in the abdomen. We see jaundice due to a buildup of bilirubin. Encephalopathy, so toxin buildup that affects the brain. Esophageal varices, high portal pressure causes veins to swell and rupture. I hope now that all these symptoms are clear to you based on what we talked about in the previous slides. We said a crucial part of normal liver function was the role of albumin and its role in preventing edema or controlling oncotic pressure. That has now been lost, right? So we will have a buildup of edema or fluid accumulation. Another crucial role of the liver was to break down bilirubin to avoid excess buildup. That has been lost. And the symptom we see with the buildup of bilirubin will be jaundice. Another role was the detoxification role of the liver. That has been lost. So toxins will build up and affecting our brain, leading to encephalopathy. And we also mentioned that as the stage develops and we go from normal to fibrosis and moving into cirrhosis, we will also have scarring around the portal vein, leading to increased pressure. And when that happens, that high portal pressure will cause the backflow pressure to increase, leading to the swelling and rupturing of our veins. And we will see this as esophageal varices. Now, if this isn't bad enough, as you're probably noticing, we're talking about this stage, stage 4 here. We then have a final stage called liver failure. So here we have a severe dysfunction, right? The liver's inability to detoxify, to synthesize proteins like clotting factors and albumin, and to process nutrients will eventually lead to systemic failure. What would be the symptoms we will see at this stage? We will see coagulopathy. So we will have bleeding tendencies due to a lack of clotting factors. Because without going into details, if you haven't already studied blood physiology or hematology, these clotting factors, factor 3, factor 7, factor 10, etc., fibrinogen, they all play a crucial role in making our blood coagulate. So when there is let's say this is a blood vessel, you have for whatever reason, a damage to this vessel wall, you want our platelets, right, our thrombocytes that are in our blood, to come to this spot and clot it. And this is to prevent bleeding. Now, these clotting factors we are mentioning here that are synthesized by the liver, these factors are extremely inherently important and crucial to activate this process here. So I'm simplifying right now, but for those who don't know, to get these platelets to actually stop this bleeding, you need these different factors, these clotting factors to be present. So you can imagine if the factory, the liver that is supposed to produce these, is dysfunctional, we won't have these. And if we don't, well, bleeding will increase. We also mentioned that another super key role, very key important role of the liver is storing glucose. And if we have a loss of function here as well, we will see hypoglycemia, which is a failure due to regulating glucose. So the liver stores glucose, like in the form of glucagon. When the blood sugar level goes down, the reason why we don't normally crash is because our liver has stored a lot of glucose, so it releases it. And when it does, we can then utilize that to get our blood glucose level normal. And as we eat nutrients, this storing of glucose continues. But Again, liver function or liver failure means that we've also lost this function. And of course, we will see multi-organ involvement like kidney dysfunction in hepatorenal syndrome, for example. Why this is fascinating is because you have a pathology, you have a problem, liver failure, that presents with very, very specific and sort of easy to notice symptoms. But why it's so multi-organ, or why it's so multifaceted? Why are there so many different areas that are presenting? All the way from edema to jaundice to bleeding in the esophageal varices, for example, or hypoglycemia. It forces you as a med student to go back to the very, very, very basics and ask yourself, what is the function of this organ? What does it do? And when you realize that you can discover 10, 15 different things, all of which have very specific and dangerous consequences if disrupted, not only do you then connect this clinical section with the basic physiology that you study, it also makes medicine more interesting and fun. At least for me. So now then, let's go back to hepatitis type B symptomatology. So acute infection, you will have about 30 to 50% of adults being symptomatic. We divide the symptom phases into the prodromal phase, the icteric phase, and the resolution phase. Again, this is when we're talking about an acute infection with hepatitis B. So in the prodromal phase, you will see fever, fatigue, nausea, vomiting, perhaps anorexia, and joint pain. When it's in the icteric phase, we will see signs of jaundice, so the yellowing of skin and eyes, dark urine, pale stools, right upper quadrant pain. And then in the resolution phase, you will see symptoms gradually resolve in weeks to months. If it's a chronic infection, it is often asymptomatic until the different complications we've talked about arise, like cirrhosis. It can cause fatigue, mild right upper quadrant pain, and elevated liver enzymes. Which is also why it's super important that if you do know that you are diagnosed with hepatitis type B, for example, that you have your yearly checkups to make sure that your values are all right. So in our blood workup for diagnosing hepatitis type B, we will first look at serological markers like the hepatitis B surface antigen. So the presence of the hepatitis B surface antigen in the blood will indicate an ongoing infection. So this antigen is a component of the hepatitis B virus envelope, and it is the first detectable marker in an acute infection. Usually it appears within 1 to maybe 8-10 weeks after exposure to the virus. So surface antigen of Hep B means it's a current ongoing infection. Then we have the hepatitis B surface antibody. This one indicates immunity to hepatitis type B, either due to recovery from a previous natural infection or from a successful vaccination. And it is typically detected in the blood after the clearance of the hepatitis B surface antigen or following immunization with the hepatitis B vaccine. Then we have the hepatitis B E antigen. So the E antigen is a marker of active viral replication. with high levels of infectiousness. It is secreted by cells infected with hepatitis B, and it is found in the blood when the virus is multiplying. So its presence, the presence of the E antigen, suggests to us that the infected individual has a higher potential to spread the virus to others, for example, through blood or body fluids. So in an acute hepatitis B infection, the E antigen usually appears shortly after the surface antigen, and it disappears as the infection resolves. But in a chronic hepatitis B infection, the E antigen, the persistence of the E antigen indicates active replication, while its loss, along with the presence of anti-HBE antibodies, is often a sign of lower replication and infectivity. This is called immune control, essentially. And then we have the hepatitis B core antibody. So if we have immunoglobulin M, it will help us recognize the recent or acute infection. If it's immunoglobulin G, indicating a past or chronic infection. Now then, moving on to liver function tests. So we will expect seeing elevated ALTs and ASTs during active infection. If you're not super clear on what ALT and ASTs were, please check our previous lecture on hepatitis type A, where we discuss it in more detail. Then we have the hepatitis B DNA. So this quantifies the viral load. It assesses for replication and then helps us guide treatment decisions. We can also, of course, use imaging like ultrasound or elastography to evaluate fibrosis or cirrhosis. Now let's look at some differential diagnoses of hepatitis type B. So let's differentiate it with Hep A. What is the key differentiating feature between hepatitis B and hepatitis A? So hepatitis A is acute, self-limiting infection. It has no chronic phase, and it's confirmed by immunoglobulin M anti-hepatitis type A. So this should immediately then, I would recommend writing it down, that hepatitis A can be differentiated from hepatitis B because A is acute, it's self-limiting, and has no chronic phase. What about comparing hepatitis B with hepatitis type C? Well, hepatitis type C has chronic infection, which is more common, and it's confirmed by anti-hepatitis type C and hepatitis C RNA. Hepatitis D requires a co-infection with hepatitis B. So there should be a positive response to hepatitis B surface antigen as well. Alcoholic hepatitis, so it's usually associated with heavy alcohol use, where AST is more elevated than ALT, usually in a 2-to-1 ratio. Comparing it to autoimmune hepatitis, you will have a positive ANA, or anti-smooth muscle antibodies, and this one will respond to corticosteroids. Then we have non-alcoholic fatty liver disease. It's common in metabolic syndrome, has no viral markers, but has elevated liver enzymes. Now, I don't suggest that you memorize this right now. I would rather recommend looking at our coming lectures on hepatitis type C, D, and E, and then return back to differential diagnosis, and it will hopefully be very clear to you how you can differentiate between these different types. Moving on then to treatment and management of hepatitis type B. So if we have an acute hepatitis B, it is usually self-limiting. Supportive care is enough, like hydration and symptom management. However, if it's chronic, we use antiviral therapy. So first line, tenofovir or entecavir. The goal is to suppress the DNA of the virus, normalize our ALTs, and prevent complications. Naturally, in chronic hepatitis, as mentioned before, we monitor for the development of cirrhosis or HCC. So we do regular liver ultrasounds and check AFP levels. And of course, if it has developed from fibrosis to decompensated and on to liver failure, we need to do a liver transplant. Let us just briefly look at a case example for hepatitis B. So a 35-year-old man presents with fatigue, loss of appetite, and abdominal pain for the past week. He reports dark urine and yellowing of his eyes, so jaundice. He works as a healthcare worker and recalls a needle stick injury 2 months ago, and he's unsure of his vaccination status. We do our workup. In our physical exam, we see jaundice. Furthermore, another important symptom is right upper quadrant pain or tenderness. We do our labs, we see an elevated ALT and AST. So there is no 2-to-1 ratio, right? For example, which could indicate alcoholic hepatitis. We then look at other blood results, and we see that there is surface antigen of hepatitis B and anti-hepatitis B core IgM antibodies, both indicating hepatitis B. We see negative anti-hepatitis B antibodies. So this will then, or this should prompt in your mind the question, is it acute or is it chronic? We have the presence of surface antigens. This indicates an ongoing infection. But how do we know that there is no underlying chronic infection and the patient is right now just experiencing an acute episode? Well, precisely because we get a negative anti-HBs antibody result. So this patient doesn't have antibodies present enough in his blood against hepatitis type B. So his body has not been subjected to hepatitis B before enough to produce its own antibodies. So this tells us that this is an acute hepatitis type B. And what do we do when it's acute? We give supportive care with rest and hydration. We know that it's self-limiting, but we do close monitoring with liver function tests to make sure that there will be a resolution and no progression to chronic hepatitis. We can also advise household members to get an HPV screening and vaccination if they are susceptible to it. How can we prevent hepatitis B? Well, vaccination. It's safe and highly effective. It's routinely given at birth with boosters in childhood or for high-risk groups. Post-exposure prophylaxis. Another prevention could be safe practices like avoiding shared needles, safe sex, proper sterilization of medical instruments. What are some complications of Hep B? Well, we've mentioned most of them here. We talked about cirrhosis, so progressive liver scarring leading to liver failure. Hepatocellular carcinoma, HCC. So chronic hepatitis B is a major risk factor for liver cancer. Another rare one is fulminant hepatitis. This is severe liver failure in acute cases. And co-infections, like with hepatitis D. If you remember in the differential diagnosis, hepatitis D presents with the co-infection of hepatitis B. So, increases risk of severe liver disease and B, HIV. So, in summary then, the pathogen involved for the development of hepatitis type B is the HBV virus, which is a DNA virus. This is good to know because it will help you differentiate from the ones that are, for example, RNA viruses. The transmission, it's bloodborne or through sexual contact and vertical transmission. So, for example, from mother to child. Clinical features, if it's acute, fever, jaundice, fatigue. If it's chronic, cirrhosis, liver failure, or hepatocellular carcinoma. In our diagnosis, if we discover a surface antigen, it indicates an active infection. And the viral load will be HBV DNA because it's a DNA virus. Treatment, if it's acute, supportive. If it's chronic, we give antivirals. Ways to prevent hepatitis B: vaccination, safe practices, post-exposure prophylaxis, etc. For our med students, we recommend stopping and pausing the video right here and just look through these high-yield points. And that's the end of this lecture. Thank you for listening. If you liked our video, please like and subscribe for more videos.